on. But the bottom line is a tooth does not know if it's stainless steel or plastic putting the forces on it. It moves, and it moves according to the physiology, the directions, the physics, and that's where you need to think differently. Instead of thinking as steel, where the bracket in modern appliances is this very sophisticated three-dimensional handle on that tooth to move in all dimensions, okay? Now, take that differently to clear aligners, okay? Clear aligners put pressure on teeth. It's significantly weaker, okay? And the forces and direction of forces are significantly different. And you almost have to think sometimes, especially in the anterior teeth, the limitations is that take this piece of plastic and think of a lateral incisor being a watermelon seed, wet, and trying to grab a hold of it, okay? And the fact that you have weaker forces between even these sophisticated new plastic materials that have longer, have lighter forces and longer elasticity, or a less rate of elasticity decay, okay, which makes them all critically important. Now, with brackets, obviously we've gone through a metamorphosis over the last 50 years with different types of wires. We have night tie, TMA type wires, stainless steel, braided. All these are very important for applying different levels of forces. And then the different configurations, whether it fills up the bracket, whether it's round, whether it's rectangular, how much torque tip, all these things we can do. But there's no question with fixed appliances, we have more control, okay? We have more forces. And that's an advantage and a disadvantage, okay? That's one that we'll explain. The other one is that even with fixed appliances, we're still dealing with more individual teeth. That when we're doing radical changes such as arch expansion, intrusion, extrusion, even though we have a continuous arch wire on, the teeth are still individual dental osseous segments to a lot of degrees. And that translates into clear aligners that we're treating more in mass as a whole, okay? And I'll get back to why that's critically important. The other thing that's a huge change with clear aligners are attachments, and especially the sophisticated attachments with the digital technology, where it is important, is determining what forces are needed to tip, torque, intrude, and suggest the anatomy 3D to put on that tooth to help the plastic know where to position the teeth. Okay, so let's go forward from that and know that there are some significant disadvantages to clear aligners, okay, compared to fixed. One is...
Okay, go ahead.
Yes, the ones are, and I'll go quickly on that. Intrusion, okay, is not easy. Translation, as far as controlled translation, not just tipping, okay. And then also torque, where we're trying to torque roots. All these are very limited with clear aligners. The other thing is expanding arches is very limited with clear aligners. And then the other is tipping teeth mesial and distally. Say you have a missing lateral and you're trying to mesialize the root of the central and distalize the root of the canine. Those are all significant limitations that in reality clear aligners are, fixed appliances are better for. Now, ask me which ones I use to do all those things. 95% of the time now, it's clear aligners, okay? And the reason why is you understand the science and the limitations and you know how to address them. And so with clear aligners, understanding intrusion, tip, torque, translation, all these things are limitations. What do? We change the infrastructure. We change the resistance of the bone to corticotomies and knowing the physiological changes to make it.
You kill my momentum trying to make that like a boon. You went all the way in. I was trying to build that momentum to get there and say yes, and we have the solution. Okay,
So,
so yeah,
so
you make it really, really clear because that was the point that I wanted to do before.
mhm.
Most people have the perception that Invisalign cases, if you just send it to the company, wait for the clean check, accept it, and then many times the cases doesn't go exactly in the way it should go. But
Can
the
I
other,
address that for one? Can I address that for 1 minute? Because I think that's an
sure,
important part, which is why I had the preface to it. You cannot go by what you get in the ClinCheck. In these cases I'm showing, I am a huge provider, okay? And I have my own lab technicians, and I will spend literally 30, 60, 90 minutes changing it myself, okay? Because they do not understand, and we're changing the limits, okay? And so if you're going to be doing this, you have to master the limitations and understand how to overcompensate and other things. So I think that's a very important part. Now, with that being said, um, 90+% of mine are clear aligners. Let's not use the term Invisalign because let's use clear aligners, okay?
yeah, yeah.
And but I'll be honest with you, most people charge more for clear aligners. I charge more now for fixed appliances because to me, I have less control, especially since a lot of my patients I'm treating are long distance. And I want to build in every aligner what exact movement I need to get to idealize occlusion and take advantage of the wrap effect from corticotomies or whatever I'm doing. Okay. Make sense?
So Hamid, yeah, totally. Hamid
Yeah.
and I, we kind of Hamid bring me into this. He started at the beginning, like I never heard for that before. I think we were in a zero word 2 or 3 years ago, Hamid, and then you tell me a company that was doing just little perforation with something. Remember
Well,
that,
yeah,
Hamid?
but my
Okay.
first foray was taking the Wilcodontics. I'm sure probably you've heard of them. They've been
Yeah.
around
I'm
for
thinking that
quite a
first.
long time. The
Mhm.
Wilco brothers, one is an oral surgeon, one is an orthodontist, and they have very well documented over 20 some years of work that they have done. Although they've done it with regular or fixed orthodontics, and sometimes it's not in the ways that we like to use it for airway and whatnot,
Mhm.
but they have shown very rapid movement, good amount of expansion and different things. So that was my initial course. I think what you're referring to is the other tool that just makes it small.
Yeah, the little pinch. That was
Yeah.
something.
Um,
So that's what
okay.
I'm building on because, like, that was what I knew about corticotomies, right? A
Mhm.
stimulation into the bone. That's what most people seen. That is, they try to market it like a non-invasive that you can do it to the tissue, and yes, you create some inflammation point that is still helping the treatment to be faster. So then, when I go and I see rare cases, this is a totally great corticotomies. And I want that, that's what I mentioned this before, that you can tell us what is the difference. And because you gave me good landmarks, how to come back and talk about how we do it. And how is that consideration? People is curious to know if you do it flap or flapless, if you go all the way through into the roots, if you make an entire box, if you achieve primary mobility before the alignments. That would be the first part, and then we will go a little bit talking to mechanics into the setting when we're building up the clean check, let's say, when we're working on that, what to expect from that, and what is going to be my timing with the trace, what I'm going to do in my software to take advantage of that healing process, how faster I need to increase it. So let's build up first into the concept of what is your technique for corticotomies, why you make it so effective, and just remember that there's a lot of people that they never even hear about it, or if they know they don't, they maybe didn't have the opportunity to meet one of the most expert people that I know to do it.
Mhm. Okay, that's an excellent grouping of questions that we'll go into. Okay, and first of all, we took the Wilco course. It's been, I think it was 2003, and they've done a lot to get this all going. Since then, we can't go and take a course like that without, even I went because I was getting asked questions. What is this? What is Wilcodonics? And when I found out what it was, I thought it was barbaric. Okay, there's no way. But anything we do with occlusion or whatever, we need to go in, and that's why I appreciate what you guys do. We need to go in with an open mind and hear what they have to say, because when you do that, yeah, it may not be everything to everybody, but there's going to be something you get out of it. And certainly with corticotomies, there is a huge thing. Now, I didn't necessarily agree with their technique and other things. I thought it was a little bit too radical. But yet, since then, we have over 15 years. We've easily done over 500 cases, long-term results. And so, those are some of the things that I lecture on and teach in my courses and other things. But there's a huge difference between techniques. First of all, whatever you're doing depends on what you want to accomplish. If you're looking just to speed up treatment, which is what, SFOT and corticotomies are known for, then you can use a whole host of techniques. You could use, Propel, where you're going through the tissue. You can use the piezo incisions, okay? All those things we think, we don't know for sure, okay? There's controversy there, but we think that provides a wrap effect. And the wrap effect is where the bone demineralizes, where the bone thinks it's been injured or traumatized. It demineralizes by over 50%. It increases bone turnover, literally 4 to 5 times, and vascularity in the area, all these different things. Okay, the difference between the different techniques that I think is very radical difference is the amount of trauma you do. Okay, now let's take it back to what most people are going to be familiar with. Let's say you want to place an implant and provisionally restore it the first day. What's one of the most important things that everybody knows to do? Not lay a flap, right? Do a punch incision, okay? And get that into the bone, and we know it's more stable. Why? Probably because by laying a flap, you're getting that regional acceleratory phenomenon. Just by laying a flap, you get an incredible amount of regional acceleratory phenomenon where the bone starts turning over and softens tremendously, okay? And so the flap is critically important for one, and two, the amount and depth of the trauma is critical, okay? When you're doing corticotomies, remember 2 to 3. You need to get within 2 to 3 millimeters of where you want the effect, okay? You have, a wrap effect for 2 to 3 months, and then it starts wearing down. We can move teeth 2 to 3 times faster, okay? I think, and the literature's not there, I think we can move teeth 2 to 3 times further facially, okay? And so all these 2 to 3s are really, really important, okay? Now, the other part that we really don't understand, but we can't help but think it's radically important, is the bone grafting material, okay? That has a huge effect. And hopefully when we talk next week, I'll show you cases where we're moving lower incisors 5 millimeters out. We're expanding arches 10 millimeters, okay? And we lay flaps. I'll show you pictures, we lay flaps, and we've got beautiful bone, even though the teeth are 3 millimeters more facially, okay? So that's something you can't do with just perforations. And so it depends what you're looking for. If you're trying to get translation and tooth tip and root and intrusion, or you're just trying to speed up the effect, that's where the different techniques are. Now, the micro osteoperforations that you were talking about through the tissue, it's still not absolutely, I'm not convinced, with the literature that we're getting as much wrap effect. In fact, clinically, I know. Now, I do see something, but it's very misleading because we still don't totally understand what the optimal time to trade out aligners are. It used to be 2 weeks. Then all of a sudden they had this epiphany and said, okay, no, we changed our mind. And now it's 7 days now. And so really, what is it? And so that's where a lot of these techniques where we could cut the amount of changes in half were really, neutral, because, we can use vibration, we can use punches and you can cut it in half from 14 to 7 days. Now we know that we can do that anyway. It's how much more we can shorten it. That's important, okay? But the other thing is determining what exactly you need. Anytime we do a corticotomy case, we do a flap. In my surgeon, Mike Curry, is amazing and fast. And, you know, if we talk more about the interdisciplinary process, which is a 2-day interview by itself, you know, we talked that a mature interdisciplinary team thinks alike. Why? Because we understand the common knowledge and what it takes to really utilize each other fully. That common knowledge that cuts across all disciplines. So now Mike knows that when we're doing a case, he understands where I'm wanting to move and how I'm wanting to move the teeth, which radically changes his corticotomies. And all this is based on occlusion, which is kind of our topic here. But, you know, with the days of the corticotomies being buccal and lingual and palatal flaps, you know, barely scratching through the cortical plate into the medullary bone and then packing all this bone grafting material in there, are hopefully gone, because that's wrong. It's a much more precise, individualized plan and treatment plan that needs to be. For instance, if we have constricted arches and traumatic occlusion in a very unaesthetic results, that we want to provide volume, you know, get protraction, not retraction, create volume, we have to change the infrastructure, okay? And when we're doing that, just going facially, there's absolutely no reason to do a palatal flap or a lingual flap. You just don't have to do it, okay?
Because you're moving out.
You're moving out. The only resistance you have, you know, palatal or lingually is a periodontal ligament. And we know that we can easily move that and get, you know, really distraction, osteogenesis, and the periodontal ligament going. So there's absolutely no reason to do the palate. Now, the same thing is true for intrusion. But if we're going to translate teeth to close an extraction site, say, okay, you want the same amount of wrap, buccal and lingual, okay? If you don't, you're going to have a nice wrap effect where the resistance to tooth movement is reduced by 50% on the facial, but not the palatal. And then you might get rotation and resistance and all those kind of things. And so understanding, thinking like a tooth, not knowing if it's plastic or steel or whatever, you've got to think scientifically about what you're trying to do to accomplish that.
I'm so glad you mentioned that. I love the fact that you mentioned that, because even though I haven't taken your class, I thought about the same thing. And we have a couple of cases with Javi going on right now where we are doing exactly that. And I did not lay the flap on the palatal because it just made no sense to me, because we're coming forward and outward. And
absolutely. And on top of that, you know, you can talk about it a couple different. You lay a flap, much longer procedure, which costs more, much more bone, and possibly growth factors if you use those, which is expensive. And really, most importantly, the morbidity and discomfort associated with lingual and palatal flaps is huge. Absolutely huge. People talk different. They feel like they got sand in their mouth.
Yes.
And so if you don't have to do it, we don't have to do it. Another thing you might not think of, if we're trying to develop arches, and this is where we'll quickly marry what we're doing with the limitations of clear aligners, okay, as opposed to stainless steel, we need to think about the corticotomies differently also. For instance, if we're developing arches, or if we're trying to protract to create oral volume, improve airway, and, you know, create what we call a dental facelift, change the way the soft tissue drapes on the face, and improve their airway and improve their occlusion, which is what we're here for. We don't do corticotomies on the second molars. You know, why would we not do corticotomies on the second molars? Well, because that's our anchorage. We have to understand and know that not do corticotomies where we don't want the wrap effect, because if you try to expand arches with these flimsy little clear aligners from the second molar to second molar, you're not going to do it. If you're expanding in your ClinCheck 1 millimeter, 2 millimeters, you're not going to get the expansion. In fact, what you're going to get is probably minimal. You're going to actually get some compression of the second molars even. So it's it's important to understand that. Now, if we want to intrude an entire arch in mass and change vertical dimension, which we do all the time, then we need to do corticotomies on the second molars. And if you really understand anthropology, which is a topic I would love to get into, that the second molars erupt into an entirely different bone, and their way out usually to begin with compared to the first molars anteriorly. So the position of the second molars determines how much we can get, expansion we can get with clear aligners, believe it or not. So those are just a few things that
Beautiful.
are pretty.
Thank you. This is a little bit of a selfish meeting for Javier and I.
Yeah.
Because we're picking up all these little things and writing them down.
We get all the questions. Now, Rick, give us some, and even that you don't do the surgeries, but I'm pretty much sure you have the information.
Yes.
It's two things that we want to talk, not too long. One is how you present that to the patient, because a patient is coming for an Invisalign, and in the first place, they get an Invisalign because it's something more conservative. How the hell you engage that patient to go to a surgery? Need to be shorter because we're getting closer to the time. And let's see if we can link it with the other one. Let's do that. I forgot the other one. So
Okay.
how you talk to the patients.
Okay, that's critically important. And again, it all, to me, I get all the time, people, when, for all these years, I'm known for these complex adult cases doing ortho and full mouth recon in our interdisciplinary approach. They say, my patients just won't do that. They won't do ortho. To that, I say BS. The problem is not the patient, it's the provider. It's what you're firmly committed to yourself. Okay, what would you recommend for your wife? Okay, your daughter, your grandkids, in my regard. Okay, let that drive your passion. All right, and once you see what you can do with corticotomies, you're passionate about it. And it's not that necessarily I'm trying to make more money, because I'm going to maybe make as much money with less effort by not using corticotomies, okay? But I know I'm going to get a fraction of the result in all regards, especially long-term stability in occlusion. If I'm going for the biggest quality and quantity of change in a patient's life, SFOT fits into that almost every time, because we, modern man, talk about malocclusion, okay, is absolutely a modern man disease. The biggest problem we have is lack of bone in all aspects of the dentalveolar and lower face, okay? And that would be a fascinating topic. I would love to go down, but I know we don't have time. But
you
everything
create just value, basically, because
yes.
you as a provider say, I'm going to create value. This is going to be the way. I don't want to put in risk the roots, and we need to go this direction because this is what I want to achieve.
And another important part, when we our interdisciplinary diagnosis has 3 treatment plans. One, and first and foremost, interdisciplinary ideal. If we could do anything we can in medicine and dentistry to help this patient, what would it be? Okay, and that. Secondly, if that's not an option for whatever reason, what are interdisciplinary alternatives that we can utilize from the different interdisciplinary modalities that we have to get an excellent result with an excellent long-term prognosis? And the third is interdisciplinary phasing, okay? And so I go through all those, and I'll tell them, if I hit them, straight on and say, well, we need to do this surgery, we cut your bones and we do all this. Hell no, they're not going to take it, okay? And so what we do is we create, just like, I hate to say it, a car salesman. We create the value before. And that's where our detailed evaluation comes in, our detailed occlusal evaluation, our detailed medical, our detailed airway, and our detailed aesthetic evaluations go into and we can create, and this is where the digital technology, where Javier, you're amazing with, fits in, because that's an incredible diagnostic tool, okay, for developing what's going to be ideal from occlusion and aesthetics and everything else, okay, and then retrofitting our treatment plan into that and using that to educate and motivate the patient. But the other thing that I think is important, so we start with that, but if we don't give them other options, they're going to go get a second opinion, and he's going to say, he's not treating according to modern or to the standard of care. The AAO thinks airway has nothing to do with anything, blah, 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 blah. And so what we do is we give them the secondary one and say, no, we can straighten your teeth, make your teeth straight, improve your occlusion. We just can't take care of these other things. And so we have a secondary one, which is not bad treatment. It's more, and then instead of us doing some kind of compromised care just to get the case, we're going to do other things. Other things like a lot of times it might need orthodontics, indoor SFOT. We might do some limited things to take care of their aesthetic values, but not do anything to compromise, number one, their occlusion and airway, but yet satisfy their needs and keep educating them about what's ideal. But our acceptance rate for SFOT is sky high. It's probably as high as most people in the treatment. And it's because,
Go ahead.
I think we're going to have to go a little bit above and beyond the time on this one, Javi, because
this is a juicy.
This is unbelievable for me. Just listening to a board certified orthodontist talk about the stuff that we always talk about, it's just mind blowing. And I still want to hear how your occlusal philosophy and all that stuff Javi wants to get into. Please.
Okay, but before, let's do these two questions, Hamid, if you don't mind.
Yeah.
One is going to be what people like, again, since I saw you, I just mentioned everybody, how to people start involved in corticotomies. But I have, even for a physician, the same thing. That is too invasive. They think it's too invasive. They certainly going to see your cases. Now, people sometimes is scared because they don't see how it's going to be. They say, I'm afraid to touch a root, or I'm afraid to touch the nerve. What can you tell a rule that you say, okay, of course, if you plan it with a CBCT, it's going to be ideal, but what can be the distances to the root that you will go with the cut? You already told me, because I asked you this personally, the part of the trick here is the more trauma you create, so you prefer rotatory instruments in a state that use in more conservative ways, because it's all about inflammation. So what can be the limits interproximally to the roots and mostly to the apex in the way that you will create those corticotomies? Just to like have an idea.
Okay, phenomenal question. Okay, and thank goodness for CBCTs. Okay, we use CBCTs a lot. That's one point. Number two is when you lay a flap on a lot of these cases, you're already going to see dehiscences and the roots are already almost out of the bone. Okay, so that makes it pretty easy to know. But the hardcore answer to how deep you can go is absolutely depends on how far apart the roots are. Okay, and so that's where we have to, if you have really crowded lower anteriors that there's no room, we're much more limited. We may have to do just surface with a surface burr going through the cortical plate. Into the medullary bone, where if you have tipped teeth, or say you're taking in you have an extraction site that you're wanting to close, which we don't do very much because we are definitely about volume. But if, in that case, we're going to go deep. We're going to decorticate the whole thing. If we're treating, we're going to take a lot of cortical bone off. And so it has to do with the amount of tooth movement and how much room we have. Okay, now, Mike Curry, my counterpart in crime, who, by the way, I work with 5 different periodontists, a couple different oral surgeons. Mike I do 95% of the cases. I can tell you, we get radically better results with Mike. And I think that's because he is so confident and aggressive with them. Okay, and what he uses.
So there's no grafting whatsoever in your technique.
No grafting whatsoever,
yeah.
Did you say?
So
No, There definitely is grafting.
Okay.
Osseous grafting, yeah, that's a very important point.
Okay.
And if needed, alloderm and connective tissue grafting, all at the same time. Our philosophy is, and this is how another way we help sell these cases, which is really important. A lot of these cases have, recession or dehiscences or clefting, or a lot of times they have too much tissue and they need to have aesthetic crown lengthening. Other times, we need to do grafting anyway, soft tissue and hard tissue. And so what we do, instead of doing all these procedures, we do them at one time. And I'll tell the patient, you know what we need? You have such thin bone, your phenotype, your recession. You need to have grafting now. And while we're at it, we've already done 75, 80% of what the gum specialist has to do to make it where it radically improves the level of care and result that I can give you. So that's another significant selling point, is we do, instead of doing it prophylactically before, we do it during. And not only do we get radically better tooth movement, in my opinion, we get radically better grafting success, okay? And so that's another very, very, very important part. And let me see, what was the question again? Now I'm kind of rambling. I know, I apologize for that.
No problem. That was the question was about, I forgot. I mean, no, because I'm thinking in my next question already.
Important point I was trying. Oh, okay. I know what it was. It was about how do you plan the surgery.
Yes, exactly.
And Javier, this is where I'm going to throw it back to you. You're doing some great stuff that I really want to work with you and Octavia on more about, guides and things like that. I think those are really important, for somebody like Mike. It's might kind of get in his way, but while people are getting comfortable with it, I think that could be a great adjunct. But it has to be, in my opinion, where we lay flaps and then do the matrices, and where we have depth, we can control depth, and it's all planned in some of those videos that you've shared with me that I've used and always give you credit on. I think that's going to be a great way to help people get used to.
Yeah, we're working to standardize those better. Okay, so my next question is mostly with the timing and activation. Depends on the software you use or the company that you use, is some parameters about how much amount of movement we want for every tray. So in the software I work, I have full control of everything. So my values normally are 0.2 of a millimeter for every aligner. Normally I put it for 2 weeks, and then I do 2.5 degrees of rotation. That's like pretty much my basic setups for most of the cases.
And what was the amount of tooth movement, not rotation, but tooth movement? Did you say 0.2?
Yeah, 0.2, 0.225. Yeah.
Okay.
So then with this, what can be the smartest formula to take advantage of the inflammatory process? Should be to reduce the time that the person is wearing the aligner. So let's say that you before say that the patient change the trays every 2 weeks, you will say the patient to change the aligners every 3 days. Mm-hmm. Or you will change the formula of the movement to say, I'm gonna increase the movement to 0.6, based on the formula of how much you can speed up the treatment. What do you think can be the ideal way? Change the aligner more often, or change the formula into the planning case?
Oh, that's an easy question. Both. Both.
Can I interject? One thing that addition of movement, it does make it more difficult for the aligner to sit. Personally, in my experience, I've learned that if it's a shorter but faster change is better than to try to put
bigger.
Absolutely. Okay. And I agree with you. Now, especially if you're doing aligners yourself, though, that does save cost, but I think it comes at a cost of maybe the result, but certainly patient comfort. Okay. And, obviously we're going through this. And before I forget, let me say something about the last question, and that is
Sure.
typically how deep we go. We got to be aware of the roots.
Okay.
But I can tell you, we do part of SFOT, surgically facilitated orthodontic therapy. Corticotomies is a part of that, and individual osteotomies, where we do individual dental osseous segments, okay, and individual implant osseous segments. All these are radically different. But with corticotomies, the morbidity is almost non-existent if you have any clue what you're doing. Every once in a while we get recession. It's because of elastics. We have yet to get a devitalized tooth. We have not lost a tooth. We've had several rounds of maybe infection, which we cleared up with antibiotics. So the morbidity is very low. Now, dental osseous segments, the morbidity is very high. You can get devitalization easy. You can get major bone loss. You can get loss of the segments. So it's radically different on that. Okay. Now, back to what we were talking about. Now, what I'm going to tell you is my formula. Okay. Mm-hmm. There's really not the evidence we need to say this is absolutely the best. But what I'm going to do is tell you what we've done, used on over really 500 cases that we've done corticotomies with clear aligners, okay, and the protocols that we've used. And I agree with both of you all. We need to modify and change the velocity, let's call it, of tooth movement per aligner, and use the quantity of day change to our advantage, okay? So what I do is I feel less is more. And so less tooth movement per aligner is more efficient because it applies less stress, okay? And we can change it out faster, which leads to less elasticity decay in the aligner, okay?
Good point.
And plus motivating the patient, okay? We use speed of tooth movement the same way we use aesthetics to motivate the patient to do what we need to do as healthcare professionals, okay? They like changing out aligners fast and seeing treatment. They love aesthetics, okay? So what we do is we use 0.15 velocity in the aligners, okay?
0.15. Oh, Jesus. Yeah. That's a propel.
Yeah.
Okay.
Yeah. And so instead of the normal 0.25, okay, now when you change it, you're going to get more aligners, not as many as you think. You're going to get significantly more, but not as many as you think. Now, with that in mind, patients like it because it doesn't put as much force on it. It feels comfortable. And, at first, before the corticotomies, we'll have them wear it once a week just to get used to it, okay? A week after the corticotomies, when the wrap effect jumps in, we start having them trade out every 3 days, okay? And they go through those radically fast. And so what that does, to summarize, less force feels better. Less force, we can change out faster, which leads to a clear aligner, okay? Clean aligner that patients like. And the other thing, they think they're making progress faster, which in reality they are. But the other point I was going to make on that is when we have 2 months, 3 months to make hay, okay? And for that wrap effect, the last thing you want to do is have a tray that doesn't track and have to do a mid-course correction, because you're going to lose a lot of what you gained, potentially can gain in the surgery. So having these smaller intervals is really good for making sure it's tracking. And if they lose a tray, they can go on to the next one and wear it twice as long and not miss a lick. Okay, so all those things. So that's where we are, and we are doing some research on our cases to see if that really is the best combination. So again, those are my protocols that we use as much science as we have, but that's not very much at this particular point in time. Okay?
Very helpful.
Awesome. Beautiful. Honestly, I'm really full of information. This is beautiful. Now, we're interested to know his philosophical mind change in occlusion. So, but I think we need to start with the questions, and then he will tell us that story where he's coming from. That is a pathological concept to something physiologic now.
Really lost track of time. Okay.
Yeah. Yeah. So I love the journey I've been on. I wouldn't trade it for anything. Okay. And I think that's one reason why these concepts we're talking about come so easily for me, because I understand what's going on. Okay. So my background, you know, in dentistry, in dental school, I excelled in Crown and Bridge, prosthodontics, got into a great association with an outstanding dentist in Frank Higginbottom. Immediately started teaching occlusion at Baylor College of Dentistry in the labs, okay? And actually, on my own, with the help of great mentors like Jack Swepston and others, actually became trained in ethology. And I was doing all my restorative full mouth reconstructions on a fully adjustable Stewart articulator, okay? And I was doing the lab work. So that's my background, okay? And, you know, everything was to the net's eye or whatever. Now, has my appreciation for occlusion changed? No. Has my goals in occlusion changed? Not necessarily, okay? But everything else about it has changed. Progressing on, you know, when I decided, because of the interdisciplinary approach, I quickly figured out that I could do my best restorative by far when I had an orthodontist that would listen to me. And I would apply his knowledge and my knowledge, and we'd come up with beautiful results. And of course, this is 30 some years ago, okay? That's why I got passionate. Instead of going into prosthodontics, which I was always teaching in the pros department at Baylor, I decided, you know what, I can make the biggest difference going into ortho, okay? And because of occlusion and other things. In fact, the hardest part about my research project was getting it through the committees, because it was absolutely based on occlusion and centric relation, utilizing 6 different centric relation techniques, evaluating their intra and inter-appointment variability, okay? And I picked 6 different techniques. And the reason I did that is because I wanted to get to know the people at the time in occlusion and have them train me on these techniques. And so one obviously was Pete Dawson, you know, Ron Roth, Williamson, and others on the different techniques. Hands-on trained and certified me on a Panadin articulator. I was trained by, Bob, what's his name? The developer, he's passed away. Brilliant. And anyway, he was amazing. So anyway, I did that to take it, and I was also trained in the monitor, believe it or not, okay? And I combined these techniques. The most repeatable intra and inter appointment of the 6 techniques was Pete Dawson's. And that's what I developed for taking my centric relations. And these were healthy individuals, which is radically different than you have somebody that has internal derangements, and we don't need to get into all that, okay? But, you know, Pete Dawson became a good friend. He wrote the foreword to my textbook on interdisciplinary therapy. And very few lectures did he not quote my work, proving that his technique was the most repeatable. So that's kind of my background, okay? So where we are now. How has that changed over the years? You know, my goals for occlusion are the same. The etiology of occlusal problems has changed radically. In my appreciation, we've gone from, you know, treating teeth and jaws to treating more holistically. And, you know, I look at malocclusions, and as I said earlier, I hang out with a lot of dental anthropologists, and I love it. The question I have for you, today we know that malocclusion, you know, almost 70% of our population has a malocclusion that should be treated, okay? What do you think our hunter and gatherer ancestors were?
I don't know. I think what happened is our jaws are smaller and smaller because we have more contamination, more allergies, more everything. So our small body is smaller. The garage is always smaller. That different. I read the studies from the Australia that they have anthropologist studies, and they show, yeah, in the time they wear the teeth just because the conditions of what they eat, because they were people eating herbs and they were grinding them.
Mhm.
But if you see the relationship between the jaws, they always have more developed faces. That's
Yes.
why we lose more like monkeys kind of thing, because we were an stigmatognatic system that were prepared to have that. Today we don't have that. We have deficit in maxillas, mandibles all the time, and that's what I think the occlusion theories start creating conflicts, because we were start thinking joints, but now we have the garage and the car that they don't relate, and that's why techniques like this became really suitable, right?
Yes, you're exactly right. And so our ancestors, our hunter and gatherer ancestors, 5%, 5% compared to 70% today. Okay. Let's dissect that a little bit more. You know, sometimes up to 10. The only time that they found significant malocclusions were in populations that were sick or malnourished. Okay. Then they started having similar malocclusions
Yeah.
to what we have now. Now, bear in mind, and you talk to any dental anthropologist, they'll tell you our ancestors, number one, had perfect occlusions 95% of the time. Class 3, class 2 malocclusions didn't really exist. High angles, low angles didn't exist. Okay. Condylar degeneration didn't exist. Okay. So things are radically different. We're dealing with modern man diseases. And so my main point now is occlusion, don't get me wrong, is critically important, but it is a symptom, not the problem. And it is a problem we need to deal with, but it is not the underlying problem by any means, okay? And so don't misunderstand me. Occlusion's amazingly important to me, but it's everything else I'm looking at. TMD, you know, I no longer feel is a result of an occlusal interference, okay? Instead, the occlusal problem is a co-destructive factor in it, okay? And the other thing is, I think the malocclusion is a symptom of these other issues, okay? With growth and development in airway. And, you know, a lot of the big factors that the anthropologists will tell you is, without a doubt, it's not a mixing of the races. It's not the fact that their teeth wore more and had more room. It was the diet that led to the increased wear, okay? And we don't know for sure because we don't have these people to study, but chances are it's the wear's not from bruxism, it's from a coarser diet. Their diets, think what they were eating. They were foraging roots, and even vegetables and fruit that they eat were considerably more coarse than our refined diets. You know, I'll go over to my, and so our ancestors, number one, would nurse 2-3 years till the baby was ready, and then they immediately ate what their parents were eating, okay? Now, I'll go over to my granddaughters, and by the way, I'm having another one tomorrow.
Congratulations.
Wow.
And they will screw off a top in this bag-like thing and squirt breakfast in their mouth, okay? And so we're not getting the development down here. And by the way, when I say that dental anthropologists say that 5% of their populations have a malocclusion of some sort, they include third molars. Think about that.
Yeah.
If we included third molars today, what would the percent be?
No,
We
in the
have-
90s.
90s. And besides that, there's some really good studies in Australia, and this is something we could do a whole hour deal on. I love it. The Aborigines, you know, they have great records of when they were still in their indigenous environment, where they when they were taking them out of that, they took models on these people, okay? And then, you know, and I have it in my lecture, the first generation started malocclusion, significant, okay? And so we're treating underlying issues, and that's what leads to wear problems, everything else. So where does occlusion fit in this? When I teach, I talk about the fundamental components of dental facial problems, you know, and they are dental, periodontal, alveolar, And alveolar is divided up into two different categories. One is dentoalveolar, and one is alveoloskeletal, the relationship of the dentoalveolar complex on the base, and then skeletal, and then then TMD or TMJ, the occlusal, what has to do with the health of the jaws, the mastocytory muscles, and everything else. Then facial soft tissue, and then what we call systemic problems and all that. Now, airway is not a fundamental component of dental facial problems. Don't misunderstand that. It is critically important, but occlusion is a classification of the inner relationship of different fundamental components, okay? It's not a class 2 malocclusion that's the problem. We want to know, yeah, that's a way to talk about it and classify it. We want to know why. Is it a dental problem, a dentoalveolar, a skeletal, degenerated joints? What is it? That's the fundamental problem that we need to treat to create and fix the occlusion. Does that make sense? And
so just meaning that it's part of the system, so you believe in posture and all these components when you treat a case. Because
yes,
actually,
absolutely.
I think, Hamid, why you don't jump into the questions, because technically he's describing pretty much
Correct.
the question.
Answering a lot of the questions for us, yeah.
Yeah.
So as we send you the formalized questions, so when we say what is occlusion to you and who has influenced you, I think you've to a great deal already explained that. But in a short version, tell us what is occlusion to you today?
Occlusion today is a means of finishing a case and promoting a stable environment. Okay, now I don't believe anymore that you get a good occlusion, it's going to be stable, because there's so many other factors. Okay, one more point that I think is important for that. When it comes to our lower face, that we know that we're all deficient. Okay, that's modern man. Okay, we have a genetic scaffold that we have to build the lower face, but that's not what determines our lower face. It's the environment, the phenotype. Our lower face is formed by soft tissue function and dysfunction, okay? And I'll get to that point, which fits right into what your question was. Just like the cranium, it doesn't grow and the brain fills it. The cranium grows to protect the brain. The sockets of the eyes, they don't grow and the eyes fill them. The eyes develop, and what they need, the bone provides the stabilization. The lower face is the same way. And so if we're not using our jaws as much, we have discrepancies which lead to occlusal problems. When we have swallowing habits, or when we're breathing through our mouth with our tongue out on top of the mouth, we're going to get constricted arches because we're trying to maintain our airway. And so what I'm saying is occlusion, a nice class 1 canine occlusion with anterior guidance is still my goal. But that's not how, I don't think that's the stability. The stability is treating the other issues that led to the malocclusion to begin with. Now, when I talk about ideal occlusion, in my philosophy on aesthetics, it is absolutely one or the same. And I'm going to anthropological standards, because when you treat the anthropological standards on occlusion in aesthetics, it works, and it works well, especially when you deal with the soft tissue and the swallowing and everything else. So there's a lot more to it than
and
just
long-term stability. That gives you the long-term.
The other thing that occlusion is important to me on is in the days of having class 1 molar and class 1 canine. By the way, Angle, who's usually considered, sometimes trash because he was the plaster on the table guy, was one of the most influential people on really looking at dynamic occlusion and how it fit into growth and development. So he's misunderstood. That would be another great session that we could go into. But
we can't keep inviting you and inviting you. We like to talk. You get the two talkers. That's beautiful.
Fantastic.
No, yeah, I keep on losing track of the point of this.
Let's go to question number 2.
Yeah.
What happened is the moderator get too excited, and now he's not controlling the questions.
I know. I'm like getting lost.
But the important thing is okay, so everything has to do with, it's no longer taking out teeth and retracting. I don't think that taking out teeth causes airway problems or malocclusion problems. But what taking out teeth and closing spacing does is the case is totally misdiagnosed. The problem is not that we had too much tooth for the size, but the problem is our bone's not big enough.
Those patients that didn't have the room, they probably already started with airway problem and
They
malocclusion.
already had airway problems to begin with. And the orthodontist, whoever, missed the opportunity to help them not only with their airway, but a far more beautiful result and a far more stable result. And so anymore, spaces are my friend. Why? Because I highly respect my restorative dentist. And I love having spaces when I'm treating because I can use those to open further or whatever I need to do to develop the anterior occlusion properly with anterior guidance. I don't care about class 1 molar, whatever. I want to get a good occlusion and functional occlusion in the posterior with anterior guidance. And so I might finish with the class 3 or class 2 molars, but I'm opening spaces to correct the anterior relationship and doing what we call airway positive.
In that same respect, how do you feel about the curve of Spee and curve of Wilson? How do you try to finish your case?
Yeah, that's a difficult question. And certainly we want, flatter curve of Wilson and flatter curve of Spee. And, so that's a very difficult question to go in. So we do build that in a little bit, but most of the time we have such a severe curve of Wilson and curve of Spee that we need to correct, that we overcorrect it and then let it settle in, okay? And the very fact that we have to use retainers tells us that we're not fully doing our job at treating everything. Because the bottom line is the reason they're constricting everything else is because the tongue wasn't able to do its job to get it out there. So we can think we're these macho tooth movers and bone builders and move stuff, but if we don't address the soft tissue,
which is the next question, actually,
is going to adapt. Bone is going to adapt to the soft tissue function unless we try to hold it where it's not wanting to be.
So based on your answer, the second question, I'm assuming, which is what factors do you consider prior to stabilization? I'm going to assume that you're big on oral myofunctional therapy.
Absolutely. Absolutely. Mm-hmm. From birth. And I think my goal for the future is to treat far less malocclusions and prevent malocclusions from ever happening. Okay, and we can do that. If we properly get these kids working properly, we can prevent a lot of these severe malocclusions and treat them more holistically, which I know is one of your questions.
Yeah.
And that's where I'm fortunate. I have 2 sons. One's with me already. That's an orthodontist and board certified.
Fantastic.
And a specialist now in oral facial pain. Okay. So you asked me about my appreciation of occlusion and TMD. It's there. And then my second younger son is in his last 4 months of orthodontic residency at UOP. So, and we're all focusing on this and creating protocols and treating all the individuals, looking at all the different treatment modalities to see where it fits in to this approach. Okay.
Beautiful story there.
Yeah, it's very fun, very exciting for sure.
I know all of them. They're brilliant guys, honestly.
Thanks.
It's amazing. Yeah.
They didn't have much choice there. Which type of information and diagnostic record do you collect, Doc? I know you talked about the CBCT.
Yeah, CBCT, used to, I would, take, ideal centric relation, mount everything, do condylar tracings and all that stuff. I don't do that I don't. And the reason why is not that I don't think it's important, but I think it's more important when you're doing reconstructions. And again, just like Invisalign, it's important you know what it can do, but more importantly, know what it can't do. And then adjust your treatment so that you address those problems. Okay. Now, the bottom line is I want to know somewhat what my malocclusion is. Is there an anterior shift or whatever to start with? But I can do a lot of that clinically, okay, because I'm going to change all that. And so that part is really more important down the road when I'm finalizing the occlusion. So I don't spend as much time mounting model because it really doesn't change significantly what I'm doing unless they're having severe TMD problems, okay, which we know from the literature isn't necessarily caused by a malocclusion. In fact, malocclusion may be more a sign and symptom of a TMD problem than the opposite, okay? And I used to think it was everything, okay? So you're not doing as many mounted models and everything else, okay? Now, we are taking CBCTs, tomograms, we're doing high-res pulse oximetry. When needed, we do, sleep studies. We're doing detailed questionnaires on bruxism and all these headaches, popping and clicking. And we do treat TMD problems, okay, because that's an important part of the foundation of what we do in an interdisciplinary approach. We got to have stable jaws, condyles that are corticated and not melting away. And so we do treat those. But what we do is we know that a lot of times the etiology of what led to that is something radically different than occlusion. Occlusion and where we are is something that is a result of all those different things. So we do detailed workups. And a lot of times now, instead of looking at TMD problems as an occlusal problem, a lot of these times we're looking at now as more of an airway problem that has secondary TMD problems and a secondary malocclusion, if that makes sense. And I think that's a really important part about how we address it. We don't look at it, where we're going radically different, but how we're getting there and how we're trying to make and treat holistically and much better. And when through all my nephology and all my training and teaching, we were always taught that there's always those crazy females that you just can't help. Has anybody heard that before?
Absolutely.
Yeah.
Okay. And need to get a psychiatrist and all this stuff. And I'm calling right now BS. I don't want to use BS because these are patients that have chronic fatigue, chronic pain. They have fibromyalgia, all these buckets medicine puts them into, and they're taking all these medications. And what I feel they have is upper airway resistance problems that we need to deal with. And they have these huge maxillators. We can't prove that airway causes clenching and bruxing, but some reason these bruxing and clenching problems go away when you treat the airway, okay? And instead of looking at the adult basket cases or the young developing cases as some of the most important patient pools for new patients, I'm looking more at the mothers of my traditional orthodontic patients as people that we can change the quality and quantity of their life and make them more beautiful. In reality, looking at occlusion, airway, and all the different things, my question for everyone is, who else in healthcare can treat major underlying health issues and make them more beautiful at the same time?
Okay.
That's what we do.
Yeah.
Amen. That's what we do.
That's right.
Question number 4, I think you sort of already answered. It's about the instrumentations that you use, and I think you kind of went over it in the previous question with the CBCT and tomogram and pulse ox and all that. And question 5 is about the interdisciplinary approach, which you wrote the book on it. So we're going to put a yes on that one.
Absolutely. I couldn't function without my team.
Fantastic.
And communication and collaboration. That would be another topic sometime.
Absolutely.
In selling the case, you got to have your entire team on the same board. And it starts with common records that goes to each provider. They're going from the same starting point, and they can venture off into their area of expertise, but they take what you started with and embellish it. And it's changing the perceived value of the patient over the course of the year.
Let's talk about that in your sequence of treatment. Let's talk about a little bit about those and how do you analyze the case and do you ever well, you did talk about intrusion, but do you ever open the vertical?
Absolutely. And we open it with corticotomies. We close the vertical with corticotomies, okay?
Okay.
We open the vertical with corticotomies, but don't think that we can, we can intrude and I can change, when we get back together and I can show cases, we'll show you radical changes in vertical relationships. Vertical relationships has a huge impact on occlusion, anterior posterior, okay, and airway, okay, because if you have a collapsed vertical, you have less room for the tongue, you're going to have a bigger chance for airway issues, okay. Opening the vertical up has the same effect. You may have a little bit more room in there, but due to the rotation of everything, you get your Sterling resistor, the constriction at the angle of the mandible and the oral pharynx. Okay, so we radically change vertical, positive, and negative. And the way we do it, increase vertical, is we'll go in, everything's done digitally. We determine through different techniques where we think the vertical should be, do a digital scan at that relationship, and actually indirectly mill PMMA onlays that we bond over whatever they have in the molar to open their vertical. Then we do corticotomies to extrude all the teeth to that. It works amazing. Okay, because
so that is going to drive another question. You said you kill by your own tongue. So then you increase in the vertical dimension, and then are you putting the occlusal top in all the teeth, or you using like occlusal tops into the back one just to establish your vertical dimension, and with the clean check you instate these movements? How many teeth you put the blocks on, and which teeth you do it?
Typically we'll do them, we'll pick which teeth need to be restored anyway, okay? And usually in these cases they need restorations. And so typically I like to get the lower first and second molars if possible, just to get it. And we open that up, and we, like if they have a gold crown, I don't care what kind of restoration you have, we're gonna bond on the top of it. So we're not doing the typical provisionals. Okay, now let's take that step forward a little bit, because we know that the body will adapt. If we open the vertical, it may change down. Okay, and so just like we don't do SFOT on molars when we're trying to expand, second molar we're trying to expand, we use those back teeth as our vertical anchorage, all right, which is very important. And typically we end up doing some restorative with crowns to maintain that. We don't get these extruded, then come back and extrude these, because the net result is you're going to lose some vertical. Okay, you're going to anyway. But the question I have for you is, we're used to opening vertical with restorations. What's more conservative, doing full mouth reconstruction, or doing limited restorations that they need anyway, and doing the rest through addressing the alveoloskeletal and the dental-alveolar things through corticotomies and clear aligners? Okay.
No, that's why this technique blew me away, because honestly, before was too many other limitations.
Yeah, and so each case is different. Maybe we'll try to include one of those cases for my 30 minutes just to show, but there's no way we can, go into all the, but it's a combination of limited restorative and extrusion using corticotomies, which we know is incredibly stable, and opening spaces as we need to get that optimal occlusion in the anterior area, either by using their natural dentition or by opening spaces to create more natural shaped and appearing teeth through as conservative techniques as possible. Okay.
Fantastic. Yeah, that sounds a lot like the way we think when we look at cases. And
another thing that we look at a lot, and this is where the knowledge is so important. If we're closing vertical, that has a profound change on the relationship of the mandible, AP and vertical. Okay, there's some rules of thumb, and this is what ClinCheck, they have no clue what you're doing when you're ClinCheck. Okay, and so for every millimeter I intrude a first molar, I'm going to get a 2 millimeter change in the vertical position of the lower incisors as a rule of thumb. Vertical. AP-wise, for every millimeter I intrude a molar, I'm going to get 0.6 to 0.7 millimeters anterior change from that rotation of the mandible. Okay, does that make sense? And that's going to be more like even 1.5 to 2 millimeters in the chin for every millimeter back here. And so this is what, you know, the rationale in the you know, clinical, the scientific problem-based approach that we do with, you know, to the science that we have. We can be very, it's not just flying by the seat of your pants what we do. It's highly choreographed, and it's highly structured for all these changes. And then the opposite's true. If I open the vertical millimeter back here, it's 2 millimeters here, and the lower incisors are going to go back, you know, 0.6 to 0.7 millimeters. Okay, just because of the rotation of the mandible, that I need to either open spaces for on the lower to correct, or retract the uppers, which obviously we don't want to do in most cases. Okay.
Sounds great.
Good.
All right, so I'm assuming the answer to this one, but please tell us, at which state do you consider facial aesthetics for the final treatment?
The you know, from entirely throughout treatment. Okay. And we begin with the end in mind, you know, and we do use, you know, DSD and other techniques that, again, Javier is one of the experts on, and then retrofit what we need to do to satisfy occlusion, airway, and everything else. But here's the thing, is that we, with the interdisciplinary approach, control all the fundamental components, whether it's bone, alveoloskeletal, skeletal, soft tissue, all those things we can control and address. And so occlusal goals and aesthetic goals are there from the very beginning and throughout treatment, because we want to keep the patient looking good during the course of treatment. So that's a part of when you talk about, you know, scientific evidence and you know, dental evidence now. One of the important parts is, you know, patients' needs and preferences. Okay, and so we really focus on that, and that's one way that we can get them to accept treatment. Okay, very important.
Awesome.
Perfect.
Mm-hmm.
And now we're going to come to that your favorite question on the growth factors, Doc.
Mm-hmm.
What do you feel like, and what do you know about the introduction of the growth factors and to regenerate, help regenerate soft tissue, hard tissue in the jaw joint?
In the jaw joint.
Yeah.
Okay. You know, that's not, you know, I can give my opinion on it, but that's not really my area of expertise. I'd love to get my son to answer that. He could give you a really good answer for that. But I think we're finding out, and to me, this question goes back to what we're doing with SFOT and corticotomies. We're treating issues by, you know, physically causing trauma and other things to get these different growth factors and reparative processes working in our favor. Okay. And when you combine, you know, all these different factors when we're doing corticotomies that are going to lead to new growth and new tissue, okay, and then you combine that with all the precursor sore recruitment that we're getting with traditional orthodontics, it makes a magical mix where everything does better. Tooth movement, grafting, whatever. Now, that all being said, you know, in the future, you know, probably in my son's career, they're not going to be doing corticotomies. They're going to be doing, because we're going to understand these growth factors and other things that we're trying to do in the joints, so we can much less atraumatically generate the same physiologic response. Okay, so am I for it? Absolutely. I'm not an expert in it. I think eventually we're going to be looking at a lot of those different things as treatment of choice. We just don't know enough about it yet.
Absolutely.
Does that answer your question?
Yes,
Yes.
absolutely does. Absolutely does.
Mm-hmm.
Now, at the end of your treatment, docs, are you observing postural changes? Are you expecting them? Not expecting them? Positive, negative? What are you seeing?
Absolutely. Absolutely. That's part of our goal. And we do analyze posture, and because that is a very important symptom of everything. Okay, now, first of all, I work a lot with different people, Mark Cruz, Barry Raphael, and other people who talk about form and function and everything else. But there's one slide that I see that I think is really important. So picture, some of the ancient artists, Michelangelo and others, where they have the perfect dynamics of stability in a body, okay? And then pick somebody on a sloped incline like this that's standing, trying to keep balanced, okay? The important thing to realize is you say, which one's in equilibrium? The answer is both. They're both in equilibrium. One is much less stressful. The other one's trying to adapt to structural problems. So what I'm saying is we want to get this in everybody, and we'll see that. Because a lot of times when they have head postures, forward head posture, all these different things, that's a sign of them trying to create equilibrium for the underlying problems. And so I think, yeah, just a second. Well,
Yeah, we better wrap it up. He has baby face.
I know. It's 2:30 almost.
Oh my God.
Well,
But you see, I told you, this was fascinating, man. I told you. And a lot of people is engaged. So in the meantime, I will start asking some questions. So people is asking where you can get information about his courses. He has his website. We will ask him to give us the information. But he travels. He lives in Arkansas, and he based of the courses. Some are there, but also he's starting doing some courses, going to different locations. We have this conversation this morning. We will keep you informed. We will attach some links of reference when we have answers to the questions, but also reference also because he has a book also that he wrote about interdisciplinary treatment. So all this information, we will add it into that. But what do you think, Hamid?
We have two more questions. We have two more questions
here.
that we need to just get through. Let's do that. Doc, this is a philosophical question, and when do you think? I'm assuming that your sons already are very much familiar with your thought processes. However, I'm sure that's not what they were taught in the school. When do you think we're going to have, or do you think we're going to have this type of holistic approach in our educational system?
I think it's already starting. Certainly, we have strong pockets of it. I try to maintain as much ivory tower, connection and doing what we're doing based on science. Now we're venturing off of that some, but we have our evidence that we need. And an important part of evidence-based dentistry is not only scientific knowledge, but clinical experience in the application of that. Okay, and so I rely on that quite heavily. But I think we're going to. The difference is that we got to have the scientific evidence. All of us that are treating cases like this have to do medically based analysis and records before and after to prove that we do it. The days of us putting plaster on the table and having the big occlusion debates and all this stuff are hopefully gone. We have to have scientific evidence. Then we can start changing it. The other problem is that especially in orthodontics, and I want to be careful not to step on any toes, but the problem is a lot of the programs and everything else. My sons are part of an incredibly progressive one that they encourage me to come out and really open their minds, which I think is really important. There's still a lot of that where they're led by people who don't want to teach that what they did for 30 years was not the best treatment. Okay, so it's going to take some funerals too, but a lot of scientific evidence. And when it comes to the fundamental components, and all these treatments we have, corticotomies, orthognathics, all these things that are so important, are critical. But when in the patient's lifetime do we use them? And what we want to do is get them as early on this journey as possible. 7 years old that we recommended to see him in the A, and in what Kevin Boyd would call a 7-year-old patient when it comes to growth and development. What we can change is considered a geriatric patient already. We've missed the boat. And so we need to learn how to take advantage of normal growth and development with proper function, soft tissue function early on to prevent these problems. And once they do create, we have these different options that are all different according to the patient's age. But we just need to get the cases. Everybody listening needs to get the records and have the scientific evidence to show that we're doing is making a difference, because this should be medically based, what we're doing, and it should be medically covered by insurance. And that's going to radically change our life in the future, but we have to be scientific and not fly by the seat of our pants.
Perfect. That's a great name you brought up, Dr. Kevin Boyd. That's one of my favorite clinicians that I would love to have on one of these sessions.
He would love it. I'll call him and tell him. He'll love it.
That would be phenomenal.
He's a good
All right,
friend.
Doc, last question. Thinking of your joint and joint alone, can you tell us what do you think are the sequence of events on the opening? And while you're thinking about that, what is in these patients that you're opening, closing, bites, and so on and so forth, what position of the condyle are you shooting for? What is your ideal positioning there?
Okay, so that has changed somewhat, not really, but somewhat. Okay, now, I am a firm believer, uppermost, superiormost, treating with a healthy condyle disc relationship. I still think that's my treatment of choice. And we want to have, and especially I don't have a normal population. I get the ones that are severely broken down condyles and everything else. We want, proper cortication. I'm not a firm believer we have to have the disc in place, but we need to have a healthy, stable relationship. That's where different orthotics and stuff like that are critically important. But when I'm diagnosing, I try to get an ideal centric relation. And it's really a centric relation du jour of the day, because I know it changes depending on muscle function and everything else. So don't get me wrong, I really pay attention to muscle function and dysfunction and getting that. Now, with that being said, the uppermost, superiormost is a great treatment position because it's repeatable. Okay, and it's everything else is not necessarily repeatable. Now, do I think that's the best final treatment position? Yes, because we can control it, but we build in where they can get to a more anterior occlusion if they feel they need to, because we can build in an ideal class 1 socked in occlusion with upright incisors and they're trapped back. And that leads to trauma in a lot of different things. It compromises airway. It locks in the jaw joint. The one thing that really my years in nathology and using Stewart articulators, where you actually had the soft metal, eminences and stuff like that, they actually had to grind in, is the importance of how the condyle moves in all different directions. You have to give it that freedom of movement and guidance, but not socked in absolute vertical guidance, but gradual guidance that gives them freedom. Again, you look at our ancestors, they don't have occlusion like this. They don't have occlusion like this. They have occlusion like this, okay? And you can see where everything, and a lot of them have group function because of the gritty diet. So I still, I don't believe that I treat down and forward, but I create occlusion that allows them to come down and forward. And that can even be done in restorative, where they can have a centric relation, repeatable movement, but we finish the occlusion so they can also come forward in more anterior position. In fact, when we're treating with airway appliances, we know that the bite can change significantly. And in my experience, that changes when people were locked back and had posterior and inferior placed condyles, which stretches the ligaments and other things. You free that up, the jaw comes forward, doesn't necessarily go back, nor do you want it to go back.
Exactly.
So we can show cases that we actually treat the maxilla then to bring everything forward to let the mandible be where it wants to be, if that makes sense. Does that answer that question?
Yes.
Yes, Javier, did you want to have the part about rotation and translation
Oh, yeah.
clarified?
Oh, yeah. Okay, that's very important. So, you know, I still go by the basics where we have, you know, you basically have two joints on each side, an upper and a lower. And in one you have the rotation, and then the other you have the translation. I still firmly believe that. And that's why in vertical, we have, you know, as much, you know, we have more than enough room to change in the rotational type joint of the TMJ, okay? And so,
So you believe that is a combination, but you can take care more of one compartment to execute more rotation.
within the limit, within the small limits that we are changing it. You know, we're not, now if we're talking about, you know, a 7 to 10 millimeter change in vertical relationship, and it's, now that's a whole different ballgame. But if we're talking about, you know, more limited, and I can't give you exact numbers, but I'm not concerned really about a 3 to 4 millimeter vertical change one way or the other, because the difference in the rotational. I don't think.
Perfect. Now, what do you think your conda is going to end up into the fossa? So you want that X-ray when you see a lateral, sagittal. We're trying to standardize something.
Yeah.
Where do you think that conda will be?
Anterior most, superior most. Okay.
Okay, perfect.
Yeah. And centered, you know, more centered, but anterior most, superior most in a healthy condyle
Environment. Great.
That's
I don't know. You have more
great.
questions. Honestly, believe me. Normally, when I'm asking these questions, I have a beer for him, and I next to him, and I next to the two kids, and then we playing, so we don't feel the time. But I'm missing a beer, and I think he has patience, so we don't want to abuse him anymore. Rick, you've been amazing, brother. Honestly,
Thank
it's
you.
a totally pleasure to hang with you every time that we have the opportunity. And you know, I'm so happy. My mission is done because I always say, I mean, you need to get to see this. You need, I mean, we need to make it better, more effective. And now that we have the opportunity also to share that with more people, that's amazing. And believe me, there is more information that he has. I just narrow it down to what is important for us a little bit, but and that's why we try to coach the subject in some way, because I see he covered amazing different points, mechanics, really beautiful things that he does with clear aligners. So thank you, Rick, brother. Thank you so much.
Yes, Doc, really appreciate your time. Very kind of you to share with us all your years of experience and 500 of cases. It's just crazy numbers.
Yeah.
So there's a lot of science right there if you just do a retrospective on that.
We are. My sons are actually doing that with.
Oh, fantastic.
So we're trying to get the evidence out there to justify what we're doing and make a difference.
My
that's
God.
what we're going to
Beautiful.
holistic
Beautiful.
approach.
And dream about when I'm gonna be talking about my daughter like that. I just say every day that she wants to be a dentist. That can be my biggest pleasure, you know, because this can be amazing. I really embody with
very
them.
proud. You must
Oh
be.
my God.
My daughter, I have 3. My daughter was the only one that really talked about being a dentist early on, and she's the only one that's not. But she's, you know, she's the one. She's having our 4th grandchild tomorrow.
Wow.
Oh my God.
Congratulations, Doc. Thank you again. Thank you very much.